Good afternoon and welcome to this very important seminar series, and thank you for taking the time to be with us. My name is Mary Van Lieshout. I'm the Deputy CEO here at Goal Global, based in Dún Laoghaire, Ireland. From Crisis to Resilience is a seminar series produced by Goal Global in partnership with the Harvard Humanitarian Initiative, the Rand Institute, and University College London, with support from Irish Aid. The webinar series aims to increase awareness and engagement among academics, practitioners, and the donor community around innovations and learning in systems thinking and resilience relevant to transforming crisis to resilience in fragile and conflict-affected contexts. This innovative series entails 3 webinars, which explore the emerging lessons and best practices for building resilience in the most challenging of environments, those fragile and conflict-affected areas which are growing in number and growing in depth of complexity around us. The first webinar took place last month and explored the key challenges and strategies to progress disaster resilience in these contexts. Today, our second seminar, entitled Progressing Health System Resilience in Fragile and Conflict-Affected Contexts, explores the complex area of ensuring that health systems are strong enough and capable of responding to the most excluded of communities at a very critical time in their lives. Our final webinar in the series will be held in December and will be about urban resilience. Today, we reflect on the key challenges and strategies to progress health system resilience with research experts from USAID Momentum Integrated Health Resilience, a key global project looking at strengthening health systems around the world. We also have University College London and the Rand Corporation. Our panel of experts will aim to answer the following questions and more, because I'm expecting that from you, our participants, to feed in your questions and keep our panelists on their toes. But to begin, they'll talk about and answer what are the challenges to progress resilient health in fragile and conflict-affected contexts. What learning can be drawn from the impact of the COVID-19 pandemic relating to progressing resilient health in fragile and conflict-affected contexts? And does a resilient health system translate into health resilience in these contexts for the most socially excluded populations? These and more questions are in front of us today over the next hour and a half. And again, thanks for taking part. Just a bit of housekeeping before we start. This webinar is being recorded, and a recording will be sent via email to all attendees after the event. So please bear that in mind when you're making your intervention. If you have any questions, please type them in the question and answer section. And we'll aim to get all of the questions in front of our panelists. And if we don't, we're going to ensure that our panelists take a look at the unanswered questions and we find a way to build their responses into a response to you. So thanks for your patience with this. But let's try. Our goal, our immediate goal, is to make sure everyone who wants to be heard is heard, and to explore the extent of expertise in our audience, which is always important. And finally, if you'd like to join the webinar's social media conversation, please do so using the hashtag From Crisis to Resilience. Let's get folks talking about this. So before we begin, let me welcome our panel of experts. We've tried to combine a group of practitioners, think tank individuals, and those doing and at the cutting edge of research, so that we get those different voices and those different perspectives into this conversation, and that we build and strengthen our ability to talk across the cultures that sometimes divide practitioners from academics and sometimes divide academics from policymakers. One of our key goals is to find ways of overcoming some of those cultural and professional systemic divides and make sure that what we learn in one part of the system serves our program participants best because it's informed by the expertise across the system. So let's get to work. Let me introduce our first speaker. Mesrik Nadu is a physician and a public health professional with almost 20 years experience leading international health programs, including health system strengthening, disease prevention and control, and maternal and newborn child health programs. She has led public health projects in sub-Saharan contexts, in Hispaniola and the United States. She now leads the MIHR Health Resilience Effort, supported by Goal US Fund in the consortium and representing us in this consortium of 6 major players funded by USAID. In addition to her medical degree from Jimma University in Ethiopia and her MSc from University of Heidelberg in Germany, Mesrik has been trained in Antwerp University, University of Munich, University of Kassel, and Emory University. No better woman to start our conversation with an overall setting of the definitions and ensuring we all start our conversation with a shared understanding of what we're talking about when we're talking about health systems, fragility, and resilience. So thank you, Mesrik, and welcome to the panel. Welcome to the table.
Thank you, Mary. Welcome, everyone, and thank you for this opportunity. I will be speaking about resilience of health systems. My presentation is going to focus on health systems in fragile settings, lessons learned from the COVID-19 pandemic, and approaches and innovations for health systems resilience. Momentum Integrated Health Resilience is a USAID flagship global project working in fragile and conflict-affected settings. We work to improve access and availability of high quality, respectful, and person-centered maternal newborn child health, family planning, reproductive health, and among coordination between development and humanitarian organizations, and working in the humanitarian and development nexus, and really addressing resilience of individuals, households, families, communities, and health system. Our project currently works in Burkina Faso, the DRC, Mali, Niger, South Sudan, Sudan, and Tanzania. Recently, we conducted assessments to see how fragile settings and our health systems in fragile settings are surviving within their situation. And findings of the assessment showed that health facilities in fragile settings are often lacking basic infrastructure. Their targets of looting, destruction, health workers, we already know that in sub-Saharan African countries, especially, we have a severe shortage of health workers. But this is also a global phenomenon, but it is severe in sub-Saharan African countries. But again, in fragile settings, this even though there is shortage of health workers are not being paid for months their salary, and that salary is not even a livable wage, but it is not being paid for different reasons. And again, these settings, health facilities are faced with shortage of commodities, without functional equipment, And often they have to relocate to multiple sites for because of the different shocks that are happening or crises that are happening in those settings. When flooding comes, immediately health facilities close and they relocate and they try to serve with the minimal resource that they have. No wonder that health outcomes in fragile and conflict context show a very grim picture, and the majority of maternal mortality, mortality of children under 5, and neonatal mortalities, they are happening in fragile and conflict context. For this reason, we try to really understand with momentum integrated health resilience, we try to really come up with a framework through which our project and our activities and our interventions on health resilience are guided with. So when we talk about health resilience, we start by saying resilience from what? So our resilience should be in response to a certain exposure to shocks and stresses. And we need to really see what are the shocks and what are the stresses, and how are they interacting and how are they affecting the communities or individuals or even our health systems. And at the same time, we're also trying to relate these and see what resilience capacities are available. Resilience of whom? Is it individual, household, community, or is it the overall system? And for our work purposes, since our project focuses on the last mile, we have subdivided the health system into service delivery level and the overall system organization. And then, even though things don't happen in a linear way, one leading to the other, we try to really visualize it in a linear fashion and see that this is now resulting in what? Is it an improved health outcome and well-being outcome, or how are these entities, whether it's individuals, families, or community, or the health system, are they how are they coping up with this? Are they collapsing, or is there are they just surviving, or are they bouncing back, or are they really building forward and building better? And then we come to the health system resilience definition, and USAID has provided us with a very good definition of the ability of the health system to mitigate, adapt to, and recover from shocks and stresses. And a resilient health system can ensure the continuity of existing care and has the capacity to scale or adapt services to address the shocks and stresses. And in a way, building back better and forward can go beyond a slogan and be really realized under different circumstances. And health system resilience is also in line with the USAID vision of health system strengthening, which focuses on, at the core of better improving health outcome. We're also looking at quality and equity and efficiency, making sure that all that achievement of better outcome is not at the expense of compromising quality, or by marginalizing certain communities, or by overspending on the health system. So what did we learn from the COVID pandemic? Several problems were caused by a pandemic, and it's all known that a pandemic cracks open wide any system fractures. It just exposes. It's like a barium swallow showing where problem is, or it could be a litmus paper that shows exactly where the problem is. And that's what we learned from COVID pandemic, is that no single health system in any country was prepared to face a pandemic. But what else happened is that, first of all, health facilities were strained. And we realized that health facilities, which were already strained by the regular service that they provide in fragile settings, were even more strained with shortage of beds and wards and different inputs. And then overburdened health workers. Globally, health workers are overburdened, and there is shortage of health worker, but it was even worse in sub-Saharan African countries, which is also the reality in fragile and conflict-affected settings. And these overburdened health workers were faced with a pandemic, so that made the situation even worse. And the other one is a scarcity of, it could be personal protective equipment, medicines, and medical supplies. It could be family planning commodities, and multiple, essential medical supplies were a shortage and stock out was faced during the pandemic. And there was resistance to public health recommendations by communities, by governing bodies. And there was also inadequate and inconsistent messages and directions from governing bodies or different entities which have an impact and influence on people's behavior and people's capacity to adapt to a new or improved healthy behavior. And then the other was increased domestic violence and increased mental illness, which is the hidden burden for health systems to really address that need. And then limited economic opportunities made it difficult for the health system to function, because health system is a system that does not produce profit, or it rather consumes public goods and public services and public profit. So this has put an additional strain on the health system. And resilient health system, when we come to the resilient health system, given that what we learned from COVID, we learned that it is a function of a resilient social system. And this is the resilient for social system. This is a wheel that was developed years back. And you can see that at the center, we have the most excluded and marginalized people in society. If we are able to meet their needs, chances are we are also able to meet the need of those at a higher living condition than them. And we have different interventions that we implement on this area. At the most marginalized communities, we have a tool that we apply. That's the analysis of resilience for communities in disaster, ARCD, and that was adapted to ARCD Health. And the other is the resilience for social system tool that was implemented for other systems, market system, but right now we're using it for health system and adapting it and implementing it to map the system in time of crisis and in time of calm, and see core areas which need immediate intervention and immediate mitigation, or immediately receive the attention of the people who are stakeholders or key development or humanitarian actors. The other important segment is the social and behavioral change, and the overall systems thinking and inclusion at all times. So that's why when we initially introduced the framework, we talked about resilience from what is from shocks and stresses. That's why we need to really understand the context under which this health system operates. And there are multiple avenues that momentum integrated health resilience is using. One is assessment of early warning and response system. There is fragility analytics that we are implementing in the countries we work in. The fragility analytics has been very helpful instrument, and we will continue to use it in all momentum integrated health resilience supported countries. And then continuous monitoring of context and trying to understand what is happening, but also how our communities and households, how are they coping up with the existing crisis. And the other is existence of coordination mechanisms. We try to see we work on humanitarian development nexus, but it is a great miss to really exclude the peace nexus, because it's very important that most of, even though it's not only conflict that results in affecting the settings, but conflict also still has a high weight. And the other is risk landscape analysis, resilience audit. And most importantly, we ask, we listen, we observe, and we value local knowledges. So what is needed then to improve health system resilience? In my opinion, is we need to really, really revisit our global investments and see where do we need to invest more. And for health system resilience, I believe that health infrastructure needs huge attention. And those health facilities, they need energy source, and alternative energies available in sub-Saharan African countries. We need to think of wind and solar energy opportunities to run health infrastructure, health facilities, and also sustainable facility buildings. We cannot always document and say flooding happened and this is how they cope up with flooding. Instead, we need to really make structural change in the building of health facilities in flood-prone areas. And again, the other important bottleneck is health workforce. And health workforce is already globally, there's a shortage of health workers. So we need to really be creative in acquiring health workers who are, and really when we are recruiting them, training them, deploying them, and how do we retain them? These are really important areas and that need due attention by global actors and even local actors in health. And health equipment and supplies. These are also very, very important. And local and regional manufacturing initiatives need to be really in the radar of major donors or national actors or global actors. And the other is communication. We need to really invest in communication. Transport. Mothers should not be dying having children. Having children is a normal, natural phenomenon for any mama. So mothers, human beings, mothers should not be dying having babies. And simply because there is no transportation or there is no referral system, network is not working, there's no telephone, or, there are ways in which we can harness local capacity through cross-sectoral connection and strengthening, traditional assets into making sure that mothers get the attention they deserve. And the other is new technologies that are responsive to the needs of fragile settings, and equipment, harnessing local resources, remote sensing whenever feasible. These are the major areas that need major global investments. So we need to go beyond coordination and collaboration and really focus on integration and, most importantly, country ownership. And local government should be at the driver's seat and try to really respond our humanitarian development actions into sustainable actions. And finally, I would like to speak about technology. What are the innovation systems that are available? Our technology should be inclusive and adaptable to really local context and access to products and services need to be really at the center of any innovation of systems that we are implementing. And remote sensing, whenever feasible and acceptable for good reasons, need to be also considered. And integrating the formal and informal sector. We know mothers are in fragile settings, mothers deliver at home. There's a reason they deliver at home. And we need to really make sure that there is the informal sector, for example, those who are providing services, health services, people go to traditional healers, people go to drug vendors instead of coming to health facilities because there's always shortage there. But how is it possible that the informal sector is able to have those medicines, those supplies? So we need to really see how the informal sector is operating and try to integrate both for the strengthening health system. And integrating health resilience with other, livelihood market systems resilience, and making sure that resources are shared and also information is shared for the betterment of the health system. And the other is, again, I reiterate the importance of country ownership and in informing sustainable technology solutions and financing and investing on sustainable technology solutions. With this, I conclude my presentation. Thank you.
Thank you very much, Mesrek. And thank you for setting our agenda and ensuring that all of us have a good sense of what is and what are the components of a resilient health system, and what should we be looking for, and what, after the experience of COVID, do we better understand that countries north and south need to be cognizant of. So thank you very much. Before we go to questions for Mesrek, we're going to hear our next two speakers, and I want to introduce Erin Clark Ginsberg from the RAND Corporation. Erin's going to be talking to us about measurement. So we now have some understanding of what is and what are the components of a resilient health system. And Erin's going to talk to us about how we might measure that. Let me just give you a bit of background on Erin. He's a social scientist at the RAND Corporation focused on improving the lives and resilience of communities. And his published research is about hazard management, especially where it can affect humans and their communities. His continuing research focus is on community resilience, disaster risk reduction, critical infrastructure, risk governance, disasters in cities. He's recently been advising policymakers about the confluence of public health and disasters in light of our recent global challenges and the upcoming hurricane season. Erin has extensive experience as a project leader and a researcher employing a wide variety of methods. And so we go to that important conversation on measurement, evaluation, demonstrating evidence and demonstrating impact. Over to you, Erin, and you're very welcome to the panel.
Thanks. And thanks, Mary, for the intro. And I'm super happy to be here. And thank you all for attending this valuable webinar. I'm going to share my screen right now. We can get into it. So I'm here today to talk about measurement, and measurement is a passion of mine, a strong interest of mine. I think it's when you hear the word measurement, oftentimes it can be a little bit boring. But I pose to you today that measures can change the health system world, and they're a critical part of health system resilience and health system strengthening. So Mesrek got into this, but spent some time traveling around and documenting disaster risk reduction and community resilience interventions in 10 different countries. So I was in Afghanistan, Niger, Kenya, Pakistan, a bunch of different countries. And what I saw is what Mesrek talked about. You saw weak health systems, challenging contexts, populations on the move, infrastructure kind of falling down, hard times getting supplies, a lot of challenges when it comes to health system resilience in fragile and conflict affected contexts. And I mean, this is a major challenge. There's millions of people that live in situations of fragility and conflict. So the weakness of these health systems and the fragility of these health systems, really poses a problem when it comes to facilitating good health. And as a researcher, the first thing that I go to is the literature. I start to think, okay, well, maybe there's something that we don't know when it comes to health system resilience. And unfortunately for me, there is a strong body of work on health system resilience. You plug in some of the search terms into Google Scholar, and you get millions of results, right? So it's not that we lack the research on health system strengthening. There's a ton of research out there on what works. What one area though that I think maybe we want to warrant a little bit more attention on is the role of measurement in improving health system resilience and sort of strengthening the health system world. Measures are power, right? So measures draw attention and help you see certain issues. Measures and the way that you measure, they give voice to different populations, right? So, who's an expert and who isn't an expert, it's embedded within a measure. And then they create norms and shared standards of operating. So, you start to talk in forms of measurement, and everyone sort of thinks in terms of these measures. I think the Sustainable Development Goals are a great example here, right? They're these goals, these sets of measures that have really latched on to the public attention and the broader discourses around what is development, and how do we think about development. Other sorts of common measures are Sendai Framework for Disaster Risk Reduction Measures, which focus on disaster resilience. And then this is kind of measure adjacent, the SPHERE standards, which provide a sort of common minimum baseline that we talk about when it comes to responding to a humanitarian situation. So measures, measures are critical for thinking about health and potentially strengthening health. Unfortunately, it feels like our current approach to health system resilience measurement is a little bit broken, right? So I'm a researcher, and when I conduct my research, I strive for something that is reliable and valid, a very strong representation of the world. I don't necessarily think about, how does this representation work? How can it work? And how can we use it for change? I'm interested in this idea of validity. Practitioners, on the other hand, oftentimes want something that's useful and kind of easy to use and fits in with typical programming cycles. They're on the ground, they're trying to affect change, and that's what they care about. And then the third, one of the third major populations, those who are most at risk of, in this case, health system shocks and stresses, their voices can sometimes get left behind and not included in measures. And, as a result, they can be excluded from programming decisions. So our current approaches to measurement, maybe need some work. What we're starting to see, and this is, I'll get into the research in just a sec, but this is research that the broader group is involved in. Improving health system resilience requires measures that meet a bunch of different goals, right? So there's the classic of validity and reliability that a lot of health system resilience measures currently are striving towards. Measures also need to be representative and capture the voices of populations that are most affected by health system shocks and stresses. A systems orientation is also incredibly important. Mesrick mentioned, health systems is comprised of a bunch of different components. All of them are incredibly useful and necessary for good health. This includes staffing, early warning, infrastructure, customary institutions, state institutions, technologies, and communities themselves. We need to understand how they work in harmony. These measures also need to be useful and aligned with organizational missions and aims. It's not good enough just to have measures that are valid and reliable. You actually need to be able to use them in your programming and use them to contribute to what you're trying to achieve. And then, the last one is, I like to call this frugal measurement. They need to be pretty easy to use and inexpensive, and in many cases intuitive. As a researcher, I can afford to focus completely on doing research. But if we want a set of measures, again, to be useful, a lot of organizations are hindered by limited budgets and can't spend all of their time just measuring something. They need to go out and they need to actually do the work. So frugal measurement is important here. I want to just show some of the examples of different types of measures for health systems to give you a better sense of what these measures might look like. The first one, and Mesrick mentioned this, is ARC-D, the analysis of the resilience of communities to disasters. And it's a set of measures and a toolkit for measuring community resilience. Goal created this, and then the broader group has been working on refining it and then writing it up. And I have a journal article that I can share with you if you want to learn more about this measure. There's a challenge here when it comes to community resilience measurement. Community resilience, it's very complex. You need to include community voices. It needs to align with existing sort of resilience and disaster management policy. And then the measures need to be useful, again, to guide programming. They can't be divorced from the interventions you're trying to do. Goals come up with this great set of measures for community resilience. They're pretty simple. They're pretty easy to use. You go out to a community, you ask them questions, and then that results in their sort of resilience measure. These measures are aligned to Sendai framework priorities. Those are the framework priorities for disaster risk reduction. So they track with some of the international policy conversations. And then they can be used for baseline and endline measures, so integrated into programming. Right now, Goal is using them and has been using them for a while, and they're providing their value. Another set of measures. This is something that I've been working on for a few years, and this primarily I've been working on it in the U.S. I do think there is relevance for fragile and conflict-affected contexts and countries. So this is a CDC-funded project on incident management. So it's the systems that you put in place when you're responding to a health incident like the COVID-19 pandemic. The challenge in with this set of measures is that staff who respond to COVID and other health incidents, they're overworked. When these crises pop up, it is all hands on deck. And you can't get bogged down with a time-consuming measurement process. However, you also need to do these measures to really understand where you're at and where you may need to improve your response to an incident. So RAND, along with CDC and local health departments, are developing a set of measures for measuring response to COVID-19 pandemic, to other health emergencies. And they're really designed for performance improvement, for understanding what's going on when it comes to incident management. And how can you, as an emergency management organization, as a local health department, respond better to health threats? Right now, where we've developed this set of measures, there's a draft toolkit, and we're testing these measures in real health incidents. So COVID-19 pandemic. And if you're interested in testing the measures, actually, we're also looking for partners to help test the measures. So you can shoot me an email and we can chat about testing these measures. It's fascinating. The third one, and Mesrick mentioned this one as well. The third one is R4S, Resilience for Systems. This is a systems theoretic approach to measuring resilient systems. It's agnostic to the type of system. Any socioeconomic system, it is designed to measure the resilience too. And this includes health systems. The challenge right now is when you look at a lot of the resilience measurement approaches in literature, we talk about these systems as complex and interdependent, comprised of a bunch of different parts that work together to create resilience or create fragility. Our measurement approaches to date, though, they've primarily focused on resilience from a very simple orientation. So instead of taking these systems as a whole, they look at them in their parts. They also do not account for the diverse mix and the diverse set of stakeholders, both formal and informal, that comprise a system, right? So, this includes the state, it includes NGOs, it also includes customary governance structures. So we need a measurement approach that accounts for this complexity, that helps you understand how to engage in this system. The solution that we're working on is R4S, Resilience for Systems, this systems theoretic approach. Like the other examples, it's a set of measures, there's a toolkit, it's designed for programming. It's developed, but it's still being refined and documented. And thinking about it in a conflict setting is something we're trying to do. All right, so I'm going to wrap up. There are some lessons that I think where we can pull from these three examples. The first one, talked about this, measures are political, right? What you measure matters. Who's considered an expert matters. Who you focus on in these measures really matters. You want to be targeting, if you're trying to affect change, if you're trying to support the resilience of the poorest of the poor, you better be including them in these measures and making them visible. The next lesson is, I think developing the right set of measures, it really requires co-production between researchers, practitioners, and community members. It requires everyone working together. There's also trade-offs between validity, reliability, ease of use, and utility. You can create something that's super valid, but not necessarily super useful. So consider those trade-offs. It's a slow process, but if you're doing it right, these measures can change the world. Right now, we've been doing a lot of work on measurement in general, but we still need to be doing some work on measurement in conflict-affected contexts. That's an area that I think is kind of the next step here. And there's some specific dynamics that we're still working on and still trying to figure out. So I'll leave it at that and turn it back over to you, Mary. Thanks a lot for the opportunity to talk.
Thank you, Aaron. Really helpful information on the complexity of trying to get that frugal, efficient, easy to use measure in complex systems. And let's take that conversation a bit deeper with our participants here when we talk about how do you do that in fragile contexts where populations have been on the move and have been surviving cycles of crisis, and the system has been through cycles of crisis. I think we need that focus for our conversation shortly. But before we go there, we're going to take this discussion on measurement a little bit deeper. I want to welcome Laura Peters from the University College London to the panel and to our table. Laura's a research fellow at UCL. She's cross-appointed to the Institute for Risk and Disaster Reduction and the Institute for Global Health as an interdisciplinary geographer and peace and conflict scholar. She researches how deeply divided societies build knowledge about, cope with, and act upon social and environmental changes and challenges. So we're getting to the heart of that experience of communities in fragility and in this cycle of fragility, and with Laura's particular research focus and interests. The goal of her research is not just to mitigate risks, but also to develop actionable strategies that support community health, strengthen social environmental sustainability, and build durable peace. Laura, no small agenda there. Thank you very much for talking to us about some of your, I think you'll be bringing in some of your experience of participatory methods and the outcomes of those. and your broader work with deeply divided societies, which is often a characteristic of communities in these fragile and conflict-affected settings. Thank you, Laura.
I'm going to share my screen here. All right. Thank you so much for the warm welcome and introduction, Mary, and for the opportunity to speak today. My name is Dr. Laura Peters, and I'll be talking about how we as the global health community can be partners for health in divided societies. I'd like to begin by asking you in the audience to imagine a health system in a conflict-affected context. What images come to mind? Perhaps you are imagining run-down or bombed-out facilities and health workers helicoptered in to provide basic services with few resources and enormous needs. But there's more to the story. Even in places embroiled in violence, extreme marginalization, and with limited resources, communities themselves are leading important and highly effective health work. I'd like to paint a picture for you in rural Kenya, in an arid region embroiled in violent intercommunal conflict between ethnic groups and pastoralists, experiencing banditry and cattle rustling, and with a high incidence of domestic violence and female genital mutilation. This is a place without hospitals. The nearest hospital is over 100 kilometers away. Oops. And this is also a place without adequate health systems and services, without vaccination programs, without improved water sources and sufficient food. But this story does not stop with what this community lacks or the challenges it faces. A community health leader named Lillian Noeli established a community-based health organization called Saudi Dada in her indigenous community of nomadic pastoralists called Pokot. Lillian has undertaken an ambitious agenda to end female genital mutilation, child marriage, and domestic violence, as well as promote maternal health and child well-being through a range of activities beyond providing essential health services, including feeding vulnerable girls, providing essential education and awareness campaigns, and creating new sources of livelihoods. I'm honored that Lillian is here with us today in the webinar audience. Lillian is partnering with us on a research project I'm leading with Stemma Health Systems to deepen an understanding of community health in contexts of extreme marginalization and develop more effective modes of partnership to support community capacities for health. Lillian's work is extraordinary, but it's not singular. We know that communities need to be at the center of their own health systems, but somehow we lose this understanding in fragile and conflict-affected contexts. We begin to see communities as part of the problem rather than the solutions. Through my presentation, I invite you to challenge preconceptions you may have about how to support health systems in places affected by conflict, and where armed conflict is indeed a health risk. Let's challenge reductivist thinking about progressing health in conflict settings as merely delivering health services to combat illness and bodily harm. We need to shift away from taking a narrow focus on problems and not solutions. Solutions may not be the other side of the coin, and they may be equally complex as the problems. And finally, I'd like to challenge thinking uncritically about pathways forward toward health goals, including perhaps framing resilience as the end goal. Changing our frame of thinking may lead to more nuanced and reality-based understandings of why throwing more money, more technology, and more resources at health challenges won't solve them. A narrow focus on challenges alone does little to address the underlying structures that support alternative futures for health in fragile and conflict-affected contexts. The flip side of a problem may not reveal the solution. The tools to envision and build the futures communities want and need for their health and well-being require more than designing targeted interventions to temporarily interrupt vicious cycles of conflict, violence, and poor health outcomes. Adopting the World Health Organization's definition of health as a state of complete physical, mental, and social well-being challenges us to think beyond working toward returning conflict-affected communities to a so-called normal state of functioning. Interestingly, peace is also often reduced to the absence of violence, but it can also be expanded to denote the presence of what sustains peace, including nonviolent approaches to conflict transformation. Both health and peace are normatively and not objectively defined, and they are deeply rooted in cultures, histories, and traditions around the world. Positive orientations of peace and health encompass more than absences of what is undesirable and broaden their view to include the components, characteristics, and practices that sustain health and peace over the long term and contribute to human well-being and flourishing. So, while we may be familiar with some of the challenges that link conflict and poor health in wicked systems that are constantly reproducing and reinforcing themselves, looking at this picture won't necessarily lend itself toward revealing opportunities to support effective and self-sustaining health solutions. Positive health and positive peace may be best described as self-generative processes rather than static outcomes, and they are supported by local and place-based conditions and processes related to social interconnectedness, living in harmony with the natural environment, and the freedom to live in accordance with shared values. From this positive perspective, health and peace may be interdependent and lend themselves to creating a self-sustaining cycle of increasing health and peace. The World Health Organization went so far as to claim that investing in health is investing in peace, and the opposite may be true as well. On the ground, this means that we need to take a step back and make the effort to truly understand the values, priorities, and goals of communities, and look to community health leaders to identify solutions that strengthen both health and peace. This means looking for what is already working and supporting or amplifying it. Communities can and do navigate a dynamic stream of challenges and creatively seize opportunities to strengthen their health. Divided societies are messier than we think, but not everything is broken. Even while certain identities or interests may be in conflict, there are a lot of overlaps and boundaries are fuzzy. People are and can be united in a multitude of ways. So even while we may disagree about how land should be used, for example, we both care about our children and their futures. We both depend on the same markets for food and supplies. Where we can move away from a view of conflict-affected communities as neatly divided in a single line and train ourselves to look into the messiness of everyday social life, we can start to identify actual and potential coalitions for change. Their health and well-being is on the line. I'd like to come back to the example of Saudi Dada in Kenya. Saudi Dada also contributes to peace building in recognition that health will never be realized where there is conflict. So women traditionally tie their stomachs with a skin belt when their husbands and sons go raiding, because it is believed that the belt will protect them from any harm. Men do not go to raid if women do not wear these belts. So Saudi Dada works with women to help them understand that they are disproportionately targeted by violence and the impacts on their health and well-being. And the organization then trains these women to be peace agents and ambassadors on market days and to spread the word not to wear this belt. So promoting resilient health systems in conflict contexts may not be sufficient. We need to look to communities to identify what can be very simple solutions to resist and mitigate violence, and perhaps even become anti-resilient to the systems that harm them. So in conclusion, we need to work through partnerships with community health leaders and organizations to promote health and build coalitions for positive change. Communities are and must be at the center of pursuing their health, but they may face structural barriers to collective action and affecting change. Ultimately, partnerships for health must support community agency in pursuing their health goals and values, and challenge the conflict systems that undermine them and degrade local capacities for health wherever possible through resilience and perhaps even anti-resilience strategies. So this reaches the end of my presentation. Thank you very much for your attention, and I look forward to engaging in a discussion with you in the Q&A. My contact information is at the bottom of the screen if you would like to get in touch.
Thank you very much, Laura. And to all of our panelists, deep appreciation for bringing out different aspects of what is health resilience, what does a resilient health system look like, how might we think about measuring it, and how might we think about community responses to that, sometimes often referred to as a solution, as the opposite to a problem. And so that's really helpful. I'm conscious there's some questions in the chat. And one of the earliest questions came from Zaya Damakwatara. And I'm really going to ask our first two speakers, Mesrek first, and then Aaron, to take up this question around the application of your thinking in a system whereby there is a crisis, but the crisis is in the system as well. There's a lack of perhaps political will. There's low resources and under resources in the system itself. There's instability all around the system. So let's take up first of all, Mesrek, how do we, the difference between a resilient health system in a time of peace and then one in one of those settings. Can you speak to that, Mesrek, and the importance of initiatives and how we might have to be differently defining health resilience in those contexts? And Aaron, I'm going to pose the same kind of question to the measurement of health systems and resilience in these conflict affected settings and divided settings, as Laura has spoken about. So first to you, Mesrek, thanks. And then we'll go to some of the other questions, and then to Aaron. I'll bring you back in. Thanks.
Yeah, we talk about resilience in the context of crisis, some form of crisis. It could be conflict or not. But in times of conflict where populations are on the move there, and we have accounts where health workers are even targets of conflict. And they recently we have an experience with in South Sudan, health workers were being killed in pockets of conflict. So in this kind of situation, when there is crisis, health systems, that's why our understanding of health systems should go much broader and go beyond the health facilities or the hospital or the clinic or any institution that we're thinking, because the community, that's when the community comes into play. And a community has its own system, its own way of seeking care and its own way of acquiring care and getting treatment for their infants and babies. it may not be the conventional Eurocentric or modern medicine, but there are alternative opportunities through which community access care for their families. And there are opportunities in which the community continues to practice health behaviors. And that is why we are saying in times of health resilience goes beyond the health facilities, beyond the supply, but then the demand is the most important component especially in fragile and conflict-affected context. The community has its own way of approaching antenatal care or approaching, care for pregnant mothers, care for lactating mothers, care for infants and newborns. And the key liaison between the community and the health facilities is the community health worker, and they take different forms of training or not. Some are paid, some are volunteers, but they are the gateway to the community in terms of promoting healthy behavior and supporting mothers delivering babies, traditional birth attendants. In many of these fragile settings, we mostly think in development settings that traditional birth attendants are outdated, but they're not. They're active and functioning and providing care at home level for pregnant and laboring mothers in fragile settings. So we still have the informal sector. That's why I mentioned about really harnessing local and informal resources. Over to you, Mary.
Thank you, Mesrek. The focus of all three of our speakers has shifted us from the formal health system in terms of the provider to the communities. I think that's been fascinating, that the community is at the heart of the understanding some of the solutions to resilience in these settings, according to these three speakers. Let me bring in Erin on measurement in these difficult times. Erin, can you grab it? And secondly, Erin, there's a couple of questions from Isabel and Amin about technology in measurement. And have you thought about how technology might advance the efforts towards the kind of measurement you're talking about: valid, reliable, easy, inexpensive? So bringing Erin back in. And Erin, I might ask you to come back on camera if you could.
Sure, and I'm trying to come on camera, but it's not allowing me. So apologies for that. I'd love to. Just picking up the thread on, I'm really appreciative of the shift towards, from the formal and towards the informal in the community. And, when we're thinking about measurement, that should be central, and those community perspectives and also those community resources should be part and parcel to our measurement endeavors. One of the projects that Laura and I are actually working on, it's a project on community collective action to address the health impacts of climate change. And it focuses on Sitka and Trinidad and Tobago as our sites. And, what we are seeing is, as with other disasters, and, there's a large sort of body of work on this. As with other disasters, there's a lot of emergent responses when it comes to health crises, right? So, one of the cases that we're documenting is the COVID-19 pandemic. And what we've seen is community institutions, individuals, recognizing that there is this crisis, that there's this health threat that's also creating this economic threat and this social threat. And the state is maybe not providing as much as much as needed to create the resilience of this health system. So people are coming together and they are providing for each other, their friends, their families, their neighbors. It really is the capacities that these community members have to support each other in crisis that's critical. I would reiterate what Mesrek's talking about and say, yes, when it comes to measurement, it's not just about the formal dimensions and dynamics of the system, but it's also the informal and community, and those two coming together in harmony. The technology feeds into this pretty directly, right? So technology, just like measurement, is not neutral. Technology can be a form of power. if technology can be used to empower community voices and raise those community voices, then it can be helpful for measurement. So, you know, if it can't, if it marginalizes those voices, then maybe we should reconsider the role of technology in how we are measuring resilience. So a great example is, you know, of a potentially empowering technology would be, you know, a cheap smartphone app that you could take and you could use to talk with people, to interview people, to understand what their needs are, and to understand, you know, what their resilience is. A disempowering technology, you know, and again, this is about the use of technology, not necessarily the technology in and of itself. So, but a potentially disempowering technology, I mean, that might be something like, you know, big satellite data, where, you know, you are very literally top down collecting information and not hearing those community voices. And this isn't to say that those types of technology aren't useful. It is to say that they must be approached carefully, and that they can have certain challenges if they don't incorporate those community and local perspectives. Great questions.
Thank you, Aaron. And there seems to be, and you're back on camera, so sometimes it works and sometimes it doesn't, but we're all learning in the midst of that. So thank you so much. There seems to be, the community seems to be at the heart of the answers here. I see a question from Isabel. How do you work in these, how can you strengthen a health system when governments are really struggling with low resources and the system is so weakened in the midst of a crisis? And I think part of the answer to that, Isabel, is coming out from our panelists, that the health system is so much more than the provider. It's also all those people, the communities, the users are part of that system. Mesrek and I were having a conversation about that, this reconceptualization of the health system and the community as part of the solution and as part of, and so the resilience of the community. But I'm going to ask everyone to come back in on that. And before I go there, and I'm going to give Laura and Aaron time to think about that, Mesrek, there's some questions from the audience to you about the role of early warning systems and disaster response systems and your experience using those. And do we have learning about where they work well and what are the conditions in which an early warning system is working optimally to help prevent, mitigate, and respond effectively to a crisis in one of these systems that is so strapped? So thanks very much, Mesrek.
In a recent early warning response system assessment that we did in South Sudan, what we learned is that the health early warning system is much more, and the climate prediction and drought prediction, these are more developed, but however, they're not interconnected with each other. And a functioning early warning and response system is, it has to warn the system early enough, which means there needs to be a way to anticipate, and instead of, you know, instead of reporting there has been flooding here and flooding there, it has to be able to detect early and the rise of levels on the river and bring that to the attention of local authorities, but also most importantly to local communities, and so that the community is prepared and ready in terms of mitigating the impact of this flooding. And similarly, conflicts can be prevented, and conflict also can be predicted. And it's really important to understand how conflicts are arising. And that's why I showed that picture of the tree. We are always focused on the symptoms of the problem and the problem, but then we're not interested, and we're not digging to the causes of the problem, which are really deep buried. Those are the roots of the tree. And they're very important, that we need to, you know, the early warning system has to be able to anticipate what's coming before
way before it happens. And that's when we say an early warning system is functional. And again, the response is not only the health system response, should not be only the health provider's job or health manager's job. The health system response is should be a concerted effort of communication with the community health facility, but also the informal sector, because most of in this settings, most of the community members are not accessing health facilities. They have given up on the health facilities because resources are not there, health worker is absent. There's so many reasons that they do not go to health facilities, or maybe health facilities closed. Rather, they have an informal way of accessing medicines through local drug vendors, and then the faith-based organizations and faith institutions. These are very important for those communities, and really it's very important that we take into account all aspects of the response. So the response is going to be a concerted effort of all sectors, but also most importantly, the response of the informal sector. Over to you.
Thank you, Mesrek. We've got a couple of questions, a comment around from Roberto, that there's a concern about a large INGO spending time on this rather than on the operational, so spending time discussing this rather than operational. And I would want to argue, Roberto, that these are not mutually exclusive, that we need the discussion and we need the shared learning and we need the operational. And so I'm speaking for GOAL, but I think I speak for many people who understand that the operational can just consistently repeat problems or mistakes without learning from it and strengthening it. Our response won't be improved. So, if any of our panelists would like to add to that response. So I hope, Roberto, you can see the value in what we're doing as well as the operational work. But I'd like to go to a question from Sandra around systemic risk. And can systemic risk represent an important issue connected with risk in low-income places? I'm trying to understand, what can we see the systems and the risks within them, and how is that connected to our understanding of what needs to be addressed? And Sandra, if you'd like to further explain that, but maybe one of our panelists will take up the baton. Can I go to Aaron for a moment? And also noting, Laura, that you're an anonymous guest has deeply complimented your approach and your insightful approach to communities, divided communities having solutions to offer as well. So we're coming back to you though. Aaron, can you pick up this issue around systemic risk in that question? Thanks.
Yeah, I can try. Systemic risk is incredibly challenging to identify as it sort of comes to fruition, and then it can be hard to intervene when you're sort of faced with the systemic risk. So its origins, systemic risk originates from the broader system and then permeates and sort of cascades across the broader system. As opposed to like a non-systemic risk that has sort of a single point in time, might and originates from a single spot. That's something that in some ways is a little bit easier to measure and easier to identify, and then intervene ahead of time. A systemic risk orientation requires you pulling together the pieces of the system to really identify how they fit and how they enmesh together, and then how they interact to cascade. So doing that, going back to the measurement process, doing that requires, again, this sort of systems orientation where you're at a very high level, trying to understand how the system functions as a whole, where its strengths are, where its weaknesses are, and where its sort of cascading potential is. So, I think R4S, resilience for systems, one of the examples that I showed, that can start to be a way of picking apart and identifying systemic risks that can then be used to intervene before they cascade and turn into a systemic crisis, right? So it would be part of what we often call an early warning, early action system. So yes, I mean, feasible to identify systemic risks, also incredibly challenging. And, you know, that's some of the work that we're trying to do. Great question.
Thank you, Erin. Okay, so our last couple of questions as we come to the conclusion of our seminars. But here, Ross O'Shea has a question for you, Laura. Ross is saying in the chat, there's a common belief that people respond to disasters in a disorganized and irrational way. And I can see you nodding. It's just an assumption. Of course, we're all going to be chaotic. And yet he's saying research has shown that most respond in a constructive manner when they feel they possess the knowledge about the impending disaster. Therefore, Ross tells us it's vital that accurate, honest information is easily available to all, and misleading or false information is quickly refuted by trusted sources. But Laura, you have a view on how this can be achieved in fragile and conflict-affected contexts, you know, the contexts you've been working in, which are deeply divided communities and cultures, and how do we get that trusted information to people to enable that rational response? And then I'm going to come with a question by John Edwards on measurement, a final measurement one that I think is going to get to the heart of our conversation. But Laura, over to you first. Thanks.
Thank you so much for this insightful question, Ross. It's absolutely true that people do assume that especially divided societies are going to respond to challenges, they're going to respond to stresses, to disasters of any kind in very disorganized ways. And as you say, that's not the case. We don't see that through research in a variety of different contexts. We often see people actually coming together and trying to help each other. People in communities are the first responders to disasters. They're the first responders to crisis. And so I think that, you know, some of our work is really focused on trying to support communities as first responders. And you ask a question about how can we generate accurate and reliable, trusted forms of knowledge. And some of the research that I'm doing is pointing to the core essential need to create inclusive knowledge. So we need to look to not just even community leaders necessarily, who may not represent the most marginalized people in society, the hyper marginalized in societies, such as displaced populations, people from particularly marginalized groups, for instance. We need to look to all of these different groups that are present within society and develop inclusive mechanisms to bring them into the knowledge creation process. Because this is how we can create knowledge, create information that can be used by all of these different groups, that's relevant to their experiences and that they trust because they know that it's coming from them. And I'll add that, you know, one of the big challenges, well, there are many big challenges in conflict-affected contexts, but one of them is that in divided societies, in societies where people are sometimes pitted against each other, information is particularly not trusted in certain circumstances. And so that's one of the big challenges that we're trying to work through, is how do we create knowledge? How do we create information that works for everybody? And trying to identify people who are trying to make that information less trusted. So, you know, spoilers, as it were. And so I think that working to facilitate these conversations and discussions, to have them in open forums, to facilitate that trust, and then also bringing in views from outside of these contexts. So we want to avoid romanticizing the local. And, you know, Erin's brought up also that there are many different forms of technology and information that can be brought into a situation. So we may have these inclusive processes and also bring in this information that can be especially helpful, you know, including remote sensing data, including data on environmental changes that might be occurring, including information on a pandemic and what can be done to prevent or mitigate certain health crises. So in essence, what we're trying to do is to create these systems of information and then to communicate them through diverse communication channels that are respected, that are conducted by the communities themselves. And so this is a very long-term process that requires mutual trust, mutual information creation, and sharing. Thanks so much for your question.
Okay, Laura, thank you. All right, guys, our cup runneth over with questions. So I'm going to try to give each panelist the last two questions. First of all, Isabel Bramode wants to know, is there a global health crisis that you would believe we must build resilience to? Is there something brewing? Is there something in our midst? And if so, how would you describe this crisis? I'm interested in what this panel of experts might say. I believe there's no right answer to this, but I think people are interested in what's your burning platform? Is there any kind of consensus here? But there's a second question by John Edwards, which really interests me as I come from the field of health promotion. And I might then err on the side of believing everything happens, within the individual, within a healthy environment, but often looking very much at an individual. But I'm really interested in John Edwards' question. So if what is measured matters, how do we measure those invisible phenomena that underpin resilient communities? And I think we all know intuitively through our experience, maybe, what I'm talking about and what John's talking about. Confidence, trust, healthy relationships, solidarity, mutual support, dignity, power. In Goal, we work with log frames. They still impose very prescriptive solutions and rigid metrics that mean little to communities and actually possibly miss the heart of what John's looking at. So I am interested in how we might, okay, two questions. And we're going to go in order of Mesrick and then up to Erin and then Laura. So any burning crisis right now, Mesrick, you'd like us all to be thinking about and how you would describe that and any ideas around solutions, and then any ideas on this core question of how do we measure those things that really we know contribute to resilient communities, which seems to be the answer to resilient health systems. It certainly is part of it from all of our panelists. Thanks. Mesrick, then I'm going to bring in Erin and Laura.
Thank you. Thank you, Mary. I think two things are brewing. That's my opinion. One is I'm always thinking about the next pandemic because of this close contact with humans and animals. There is this transmission of zoonotic diseases to humans, just like COVID-19. And we really, I don't know if there's any health system who's really ready to respond to the next pandemic. And given, if we can use the lessons learned and making sure that there are teams and task forces that are already formed for COVID-19, that they can really expand their work scope and scout and see what else is out there, what are the risks, and how do we mitigate that, and really learn opportunities to document learning from the pandemic response for each individual countries, but also individual communities and states or governments. I think it's really important to look out for the next pandemic. And the other is I think about because of the effect of COVID-19 on the economy over some time, unless the economy really recovers, there could be conflict in really unusual places as well, like places that we're not used to having conflict. And unless this economic crisis turns around. And again, how do we anticipate to that? Again, continue the informal systems and continue linking with communities and form groups that could start that relationship and being able to have an idea about the risk and trying to measure what's out there.
Okay.
And gauge also information and media. That
Thank
would
you.
be important. Thank you.
Thanks, Mesrick. Okay, Erin, any ideas on that global crisis that might be facing us? And I think you're not going to escape the measurement of those interpersonal, strengths and capacities. So thanks, Erin.
So really quickly, I agree with what Mesrick said. In addition, my friends just published this book called Critical Disaster Studies, and in the introduction, they said something that really made me think. They described disaster not in terms of number of people killed, economic damage, but suffering out of place, right? And I think when we're thinking about crisis, approaching it from that sort of perspective and recognizing that a disaster of a COVID pandemic, yes, it's deadly, it's dangerous. There's other disasters that we don't think about as disasters that we should also be paying attention to. So, suffering in place would be poverty, and we live with that, and we don't think about it as disaster. And there's all of these other disasters that, they aren't out of place, we just accept them. And those are the ones that I tend to focus on, and I think, we kind of forget sometimes. So those are the ones I'm worried about. Measuring the immeasurable, that's a challenge. It takes a lot of work. There's ways of doing it. There's indicators of things that it would be very hard to measure in practice. So like an example is exhaustion, right? Exhaustion in response. One question that we're putting in our incident management measures for health departments is, how long are your shifts, right? There's simple ways of kind of getting at some of these things that are really hard to understand and see. They aren't direct, they're indirect. So they require some interpretation and they require some finesse, but they're critical. And I think, we can work towards that. So great questions, thanks.
Thank you. Thank you, Erin. And finally, Laura, any burning platform, a crisis we should be thinking about and talking about? Thanks.
Thanks for these questions. We could work to unpack these for the next hour. I know that we're at time, so I'll very briefly just say that I think that there are two major global health crises that I'm particularly concerned about. One of those is inequities in power, inequities in resources. And I'm not just talking at the global scale, but also at local scale. So I think it's important to see that there are interactions that are happening at multiple scales of inequities. And some people are consistently left out. They're consistently left behind due to these inequities. And Erin, to build off of what he said, thought it was really interesting to think about, how do we define disasters and how do we define health disasters? And, I've seen another really interesting way of framing how we understand disasters. Dr. Ilan Kelman has suggested that disasters are situations where people need outside help. They require outside help to deal with the situation at hand. And I think that one of the other major global health crises is when people need that outside help and they cannot access it. That's a major problem, especially in conflict and fragile contexts, because those are the contexts where governments, where NGOs, where many outside sources of help that we typically look to often leave because these places are not seen as good investments for resources. They're not seen as being safe or stable enough to actually conduct work on the ground. And so this starts a vicious cycle of increasing marginalization and increasing vulnerabilities in this broader system. And measuring the unmeasurable, measuring these intangibles that are so critical and so central to the work that we've all been talking about. Briefly, it's not easy. It's really challenging. And I think it requires very long-term close relationships with communities to understand how these things manifest in their specific contexts. And the last thing I'll say about that too is that, where we can start to put together measurements, we can look to asset mapping, measuring capacities and capabilities and everything that goes into that. it's not easy to compare across contexts, because when you have something that's very contextually developed, it's not necessarily going to match up with what has been developed in another context. So I'll leave it at that. Thank you very much for your question.
Thank you, Laura, and thank you to all of our panelists. We have reached the end of our time frame. We're deeply grateful to Mesrek, to Aaron, to Laura for this day and the ongoing partnership with GOAL. I hope some of the tools that have been mentioned today, the R4S and the ARC-D, are helpful to you, our participants. And we hope you join us again for our third webinar in this series, which is looking at building resilience in urban settings within within fragile and conflict affected settings. David Sanderson, Judith, the professor and inaugural Judith Nielsen Chair in Architecture at the University of New South Wales, will be moderating our panel of experts who will come from GOAL, the Harvard Humanitarian Initiative, and a senior violence prevention consultant with USAID Bureau of Humanitarian Affairs. Thank you again for your participation. To those whose questions we didn't get to, we hope that through ongoing engagement with you, we will respond and we will satisfy that need. To all of our panelists and to all my colleagues in the Resilience and Innovation Hub in GOAL, Honduras, thank you. Everyone stay safe. Best wishes.